honor and a pleasure to join you all today. I wish we were doing this in person over lunch or something, but as this COVID thing, this is the next best thing. So it's great to join you all. If I can, I'll share my screen here and have some slides. But if you know, at any point you want to interrupt me or clarify something, we have a pretty relatively small group here, so feel free to do so. Can you see my slides there?
Yes.
Great. So thanks, Phyllis, for inviting me. And so I was kind of given this task to talk about dealing with difficult diagnoses or difficult decisions, and kind of from my perspective as a neurosurgeon. So just a little bit of background. I've been here in St. Louis now about 30 years. Came to do my training here in 1990, and I tell the residents I'm in my 30th year of training and still learning. And but so I've had the honor and opportunity to treat hundreds of people with vestibular schwannomas, acoustic neuromas, and other related conditions. And hopefully I can share a little bit of my thoughts about this. And I think some of your experiences probably will be helpful for me as well to learn a little bit more about how you've all gone through this process. Here's some disclosures that aren't really too relevant to what I'm going to talk about today. And some of the institutions that I'm associated with. I'm a faculty member at Washington University and operated at Barnes-Jewish Hospital and occasionally at Children's Hospital, and we're part of the Siteman Cancer Center here. So first off, I thought it'd be useful just to make a little bit of mention of our team here. So a few of them you see pictured here, some of our ear, nose, and throat doctors and neuro-otologists in particular, those that specialize in acoustic neuromas and things of the like. And some of you are probably familiar with these. Matt on the upper right is our fellow, who I'm hopefully is going to join us as faculty when he's finished with his 2-year fellowship. Greg Zipfel, one of our neurosurgeons there, is our new chairman in this past year. So some of the ENT faculty up on the top and neurosurgeons on the bottom. And some of our radiation oncology faculty, as you see here. But these pictures just show sort of the tip of the iceberg. There's an enormous team of people that are involved in the treatment of acoustic neuromas here, the nurses, the medical assistants, the audiologists, and on and on. But hats off to all of them who kind of make this happen. Let's see, my slide is frozen here for some reason. There we go. So we work together quite a bit, in the operating room and in the clinic, and even training. So here's some of our trainees working together in the lab, trying to refine and improve our techniques. So this topic is not new to any of you, it sounds like. As you all know, acoustic neuromas, or otherwise known as vestibular schwannomas, relatively uncommon tumor. Said to be about 3,000 or so a year in the United States. In general, relatively benign and slow growing, but as you heard one of the attendees today, sometimes these things behave a little bit more aggressively, or quite a bit more aggressively. And we think these, in the vast majority of cases, arise from the 8th nerve, the vestibular component of that 8th nerve, rather than the cochlear nerve or the facial nerve. And I'll get to this a little bit later, but as you're probably all aware, there are 12 pairs of cranial nerves that control various functions, and the 7th and 8th nerves are the ones that are probably the most involved with these tumors, but a number of others that can come into play as well. So in this artist rendition here, see these nerves that arise from the brainstem, the facial nerve that's usually in the front part of that tumor, and the cochlear and vestibular nerves as they head to the vestibulocochlear apparatus, our balance and hearing apparatus. And you see a sample tumor here, a relatively larger tumor here. And remember, on all these imaging studies that I'll show, right and left are typically reversed. I like to think of it like we're looking from our feet upwards. So this is a large left-sided vestibular schwannoma there. So the symptoms, as you see here, you're all probably more aware of these than I, the hearing loss and vestibular symptoms with dizziness and vertigo and tinnitus or tinnitus. Somebody can tell me how to pronounce that word correctly, because I hear it both ways. But facial numbness, double vision, headaches, gait difficulties. I remember talking to this group some years ago, and I didn't have loss of taste on this list, and someone in your group brought this to my attention, so I've added that. In many of these, we stumble upon as asymptomatic or incidental findings. Somebody's bumped their head, had a car accident or something, has a scan, and we find them that way. So a number of ways these come to attention, and some that I've probably not included here. So this is a little bit of the gist of what I'd like to try to address today. The various time points with these tumors when it comes to identification, the decisions and choices that all of you have to make, and how you come to those decisions, and are you going to treat it at all? Are you just going to watch and wait? If you're going to treat, is it going to be surgery or radiation with the various radiosurgery devices? Or if it's surgery, mainly these main three that we sort of divided up into, the so-called middle fossa approach, the translab approach, or the retrosigmoid or suboccipital craniotomy, each with its pros and cons, each very good for the appropriate indication. Touch a little bit on some of the complications and side effects of the treatment of these and the tumors. Talk a little bit about hearing augmentation. In some ways, this is one of the more exciting avenues right now, where I think there's some great potential. To talk about this issue of what happens when these things grow back. I'll touch a little bit on NF2, more so because I think what we learned from NF2 also has helped us better treat people with solitary vestibular schwannomas too, and the thought that there may be some room for medical therapy for these, Avastin or some other agents. And so how do you come to these decisions, and who helps make that decision? And I've listed just a handful of ways that you come to these decisions. These are often identified by the primary care provider when someone goes and notes they're having hearing loss. The ear, nose, and throat surgeon, so they go by a few different names: the otolaryngologist, or the ENT surgeon or physician, or the neuro-otologist. In particular, the neuro-otologist, the ear, nose, and throat surgeon, who is really subspecially trained in issues of the ear, are typically the most helpful in these situations. We, the neurosurgeons, are involved, the radiation oncologists, the audiologists, a critical part of this therapy, particularly for people who are having vestibular or balance problems, or plastic or reconstructive surgeons, if there are facial paralysis or weakness or eyelid issues. And certainly resources, as some of you mentioned, I tend to tell all of our patients about the Acoustic Neuroma Association. It's been a wealth of information for people, and an opportunity to interact with others who have gone through or were planning to go through these. And then, information that's out there other ways. And sometimes I think it's information overload. People get information from so many different directions, and sometimes those opinions are 180 degrees opposed to each other, and trying to synthesize all that, and how do you come up with the right answer? So this is Alex Yahanda. He's one of our star medical students here. He's finishing his 4th year of medical school here at Washington University in St. Louis. And Alex, remarkably, as a student, put together an issue of the American Medical Association Journal of Ethics, and he gathered experts from around the world to talk about this issue of the physician-patient interaction. And if you have time or interest, I encourage you to look through some of those articles that he put together with some other experts. But this paragraph kind of summarizes, so if you can bear with me, I'll read through some of this. So often disease and medical treatment requires patients to take stock of their entire life, what they value, what they want from their care, and what they hope to achieve moving forward. And as such, physicians, and that probably should say physicians and other providers, must be able to take all these characteristics into account. The partnership demands more than merely a patient coming to a physician for help and physician providing service. Gone is the era in which physicians alone could make the most important decisions. Today's physicians should not only use their expertise to drag a patient towards a particular endpoint, but the physician, the patient, and their families, I would say, should be partners, traversing a treatment path in tandem, contributing equally to these crucial decisions. And so I think, in a sense, this partnership is very important, is trying to find the right mix of the provider and the patient and family to help with these challenging decisions. So some of you may know this gentleman. So Miles Penzak, I had the honor and pleasure of being one of his mentees when I was in training in Cincinnati, doing a fellowship. Miles is a well-known neuro-otologist. He presented to one of your meetings some years ago. I think this was a Cincinnati meeting, and I used some of his summary from that meeting in trying to educate people about this decision making. And so these are some of the highlights of his talk from that 2012 presentation about some of the factors that come into play. Certainly one's age. So if someone is, a very advanced age, we're much less likely to operate in them, may be more prone to watch that or treat with radiosurgery. The nature of the symptoms. For some people, the symptoms are quite severe and disabling, and they're very interested in moving forward with treatment as quickly as possible. And others, the symptoms are relatively more limited, and the findings incidental, and they may be more prone to watch. Certainly someone with general health, along with age, comes into it. Someone may be young, but if they have a lot of comorbidities, surgery may not be the right answer. This is a very important point, I think, that Miles made, was personal obligations. So in general, for example, we may think that a young person may be more well-suited to surgery rather than radiosurgery, but if that person is the sole caregiver for an older family member or a disabled child or something of that nature, undergoing surgery and that period of weeks or months recovering from surgery may just not fit in their lifestyle. So that really comes into play. And along that same line, lifestyle matters. And then a really critical thing for some people is the status of the hearing in the other ear. Fortunately, for most people, when they're identified to have an acoustic neuroma, the hearing in that other ear is good, and they can rely on that. But some people, because of some childhood problem or a neurofibromatosis, because they have bilateral tumors right and left, whatever we do to that tumor on one side has a great impact if the hearing is impaired on the other side. So each of these treatments very much must be individualized. There is no standard treatment per se, if you can consider all these issues. And certainly the size of the tumor matters. So this is from ANA website from some years ago. Some of these tumors were identified when they're very small. Now the symptoms don't necessarily correspond to the size of the tumor. Some people have a very small tumor but still have profound hearing loss or profound vestibular problems or otherwise. But certainly how we treat it is significantly affected. So a tumor like that might be well suited to a middle fossa approach or radiosurgery. And we might be able to save the hearing if there is good hearing in that ear. A more medium-sized tumor, again, there's a range of treatments. If the patient is, really asymptomatic, you could consider watching that. Certainly might still be amenable to radiosurgery. But any of the surgical approaches, except for perhaps middle fossa, could apply for a tumor of that size. And then when we get to the larger tumors, the decision-making or the choices in some ways become easier because there's more of a pressure to intervene, because once the tumor is large and becoming more symptomatic, we may not have much of an option of watching, and radiosurgery may not be as good an option because of the size. And so often those situations we're pressed to do something sooner, and typically that's surgery, whether it be translab or retrosigmoid, depending. So again, one size doesn't fit all by any means. There's not a standard treatment for any size tumor or so forth. So we got to kind of take all these factors into account. And so most all of us as physicians and providers, at some point in our training, take this Hippocratic Oath or some version of it. This Primum non nocere, do no harm. Hippocrates is apparently a historic physician on the Greek Isle of Kos, and in this do no harm concept brought forth by him is something that we all bear, and it's a challenge. So to subject somebody to a surgery or an intervention that does have some potential risk, with the hope of preserving function and maybe improving function depending, but in the process putting them at great risk. And so always walking that fine line of trying to do what's best for the individual and try to minimize their risk, but hopefully also optimize their outcome. So just briefly, and probably all of you know this quite well, but the different surgical approaches. So here's just a plastic model of the skull, sort of showing the trajectory for each of these. So middle fossa is when we come in front of the ear, so an incision right in front of the earlobe, coming beneath the temporal lobe here. The translab is going right through that the temporal bone, the petrous temporal bone, removing the labyrinth and the mastoid. And then the retrosigmoid or suboccipital coming a little bit further behind the ear. And I'll show a few more pictures to sort of describe the differences. So this is the undersurface of the brain in this drawing here. So these 12 pairs of cranial nerves that control all these different functions that you see listed here, from olfaction and vision and eye movements. In acoustic aromas, probably most critically in most cases, the facial movements, facial sensation, balance, hearing. But sometimes for larger tumors, the swallowing, occasionally some of the very large tumor may have swallowing difficulties or even be to the point of using a feeding tube or things of that nature. So the audiogram, a key part of the workup. So here we see an audiogram, the right ear here with all the responses at a near normal level, whereas in the left ear, where this large tumor is, we see they're well down in this graph. So once these numbers get into this range of 50 or above, then we think of that as non-serviceable hearing that's probably not all that useful to the individual. They may not be able to perceive useful sounds there. And the word recognition score that we see here, so on this person, 100% on the right, 0 on the left. So hearing preservation in an individual like that is just not really an option. So here another, so this is from one of my favorite medical illustrators, Tanya Hines from Cincinnati, who kind of shows the three approaches in a sense in this drawing here. So here's the middle fossa where we come in front of the ear. So here's the external canal here on this drawing of the skull. And so we make some sort of incision in front of the ear, come beneath the temporal lobe, and it's, so we're lifting up the dura, the lining of the brain there, looking at that complex anatomy in the base of the skull, trying to find those 7th and 8th nerves, and preserving the labyrinth and the cochlea and some other critical structures, the carotid artery and things that are nearby. And this is a very nice approach for somebody who has a very small tumor and one in which we want to try to preserve hearing. Often comes in use in the NF2 population where they might have bilateral right and left small tumors. The translabyrinthine approach behind the ear, essentially immediately behind the ear, where the neuro-otologist, the ear, nose, and throat surgeon, will remove a large portion of the mastoid and the labyrinth, those semicircular canals, part of the balance system, in a very direct approach to a tumor there. And then lastly, the suboccipital, the retrosigmoid approach. So this is the sigmoid sinus, the sigmoid transverse sinus. So these are very large vein or venous-like structures in the lining of the skull and brain that drain down into the jugular vein. And so, the retrosigmoid approach is behind this large venous structure, and the translab approach is in front of that venous structure. And there's some technical details of surgery that we need to consider. Just another a couple of drawings that just trying to understand the difference between these two. So this is kind of an actual top-bottom view here. So the retrosigmoid behind this sigmoid transverse complex here perhaps requires a little bit more manipulation of the cerebellum, that back part of the brain, to get to the tumor. And then the translab, where all of those structures of the temporal bone are removed, a very direct approach and perhaps less manipulation of the cerebellum, that back part of the brain is needed. So let's go through a few drawings and some interoperative pictures just to get a sense of some of the decision-making that goes on the part of the surgeon. So here's a depiction of a retrosigmoid approach. So, as many of you are aware, during surgery, often the surgeon will have your head fixed in this frame, this Mayfield head holder, this vise of sorts, to firmly immobilize the head. So here's a depiction of an incision behind the ear, behind the sigmoid sinus here, to give us that approach. And here's just a few drawings and pictures that kind of show that. So there's a somewhat larger incision but behind the ears you see here to give us that exposure here. And then what that looks like in the operating room. I'll show a brief video later if that'll work. And so here's what we see when we get in there. So here's a retrosigmoid approach for a tumor like this. So here we're on the left side, left-sided tumor. Remember, again, the MRIs are flipped right and left. So there's a left ear. So we're coming in here in that approach there between the cerebellum and the bone. And so here, once we've opened the dura, that lining of the brain, the cerebellum here, here's the tumor. It's almost like a little rubber ball, moderately firm in most cases. These are some of the cranial nerves. So those cranial nerves are like fine little wet pieces of spaghetti. They're very delicate structures. These are what we refer to as the lower cranial nerves, 9, 10, 11. They control some of the muscles of our throat and tongue. And if those are affected, that can cause significant problems with control of the tongue and swallowing. In the most dramatic case, can lead to a tracheostomy or a feeding tube if those are not functioning properly. Up higher is that fifth nerve, the trigeminal nerve, that can be associated with facial numbness or pain. And then the challenge, that the decisions that go on during surgery, is where is that facial nerve? So when we first get in there, we can't see it typically. It's on the deep side. It's somewhere buried. It's the treasure hunt trying to find that nerve that we carefully sneak up on as we slowly reduce the volume of the tumor. So we open up, we remove the bone, we open up the lining of the brain, that paper-thin membrane, the dura mater, and then we get to the tumor, and we do what we call debulk it. We remove the central portions of it so we can kind of collapse it in on itself, and that gets us into that plane between the brain, the cerebellum here, and the tumor as we hunt for those little nerves. And the cerebellum, as you'll see, is very different than the hemispheres, the upper part of the brain. They have very thin, fine gyri in the cerebellum, as opposed to the larger gyri of the upper part of the brain, where those gyri are more like the size of your finger. And again, slowly collapsing that tumor down in size till we get to that facial nerve, and we can stimulate that. So our physiologists are monitoring that continuously, which really revolutionized acoustic neuroma surgery decades ago, the ability to monitor and stimulate these nerves to help find them. And then the neurotologist typically removing some of that bone in the internal auditory canal to find those nerves at the other end of the tumor. And like this artist has depicted here, sort of shadowed that nerve underneath there. We know it's under there somewhere, but until we get down to it, we don't know for sure where it is. Is it here or is it there? And if we stumble upon it too quickly or inadvertently, we may damage its function. Quite often, in order to remove that tumor, portions of the vestibular nerve have to be sectioned or cut because the tumor is really, part and parcel with those vestibular nerves in most cases. So these are just some cadaver dissections that just give you a sense of the fine nature of some of these nerves. So we're looking into this cerebellopontine angle, that space where the tumor sits in the same orientation as this drawing here. The cerebellum is over here. You see some of these in particular, the lower cranial, is incredibly delicate little fibers there. And so the fifth nerve above, the seventh and eighth nerve, which all run tightly together, and those lower cranial nerves, and then these many delicate vessels. And so we may do a great job preserving the nerve, but if we don't preserve those delicate little blood vessels that supply blood to that nerve, even though it's intact, it may no longer function. Here's the sigmoid sinus, so a very large vein-like structure, maybe as big around as your little finger. And so great caution needs to be taken around that to avoid dramatic bleeding. Just another picture here. Some of these are from the laboratory of Al Roten, which some of you may or may not be familiar with, R-H-O-T-O-N. Dr. Roten was really a treasure to neurosurgery. Yeah, he died in his 80s here recently, but he's spent decades of his life helping us understand all of this anatomy in great detail. He actually trained here in St. Louis many decades ago before he went on to a number of other places, finally the University of Florida. But neurosurgeons and skull-based surgeons and many specialties, I think for years to come, will owe a lot of gratitude to Dr. Roten and all he taught us about anatomy. So here's a video, if it'll work for us. Hopefully you can see that there. So this is a little bit of an older video, but you see here on the right side, you see the pulsations of the spinal fluid, that continuous pulsation, that cerebral spinal fluid or CSF that circulates in around the brain and the spinal cord. There's the rubbery tumor there, and then trying to remove some of that arachnoid, that sort of wet spiderweb-like membrane, and removing some of the core of the tumor there as we collapse it. This is an ultrasonic aspirator, a device that helps us remove the tumor. And as we get it to collapse in, gradually identifying some of those critical structures, the nerves, the brainstem, and the various arteries. So there's some of those lower cranial nerves in the right side of the exposure. Start to see the brainstem with that sort of glistening, brilliant, lighter color to it. Some of the veins, this petrosal vein that we do everything we can to try to preserve. And then slowly, bit by bit, trying to remove that tumor. You see taking out a fragment of it there. We give that to the pathologist so they can analyze it. And there's the facial nerve. And sometimes that facial nerve, doesn't look quite like a normal facial nerve because it's been compressed by that tumor for maybe years or decades. And then the neurotologist sometimes drilling out some additional bone to help us find the other end of those nerves and make sure we remove that tumor as completely as possible. So that's a retrosigmoid approach there. But in effect, the dissection is pretty similar, whether we've come retrosigmoid or translabyrinthine, just from a little bit different angle and so forth. So another issue, so hydrocephalus. So the brain, as you may know, continuously produces this clear fluid, cerebral spinal fluid, or CSF, that we may refer to it as, and it's produced in these ventricles, these chambers in the brain by this delicate membrane, the choroid plexus. And in this individual, these ventricles are enlarged, and so sometimes a person will come to us, and their more immediate problem is the hydrocephalus more than the tumor itself, that the tumor has obstructed the spinal fluid pathways, and sometimes urgently, but sometimes somewhat more semi-electively, we need to put in a shunt. So that's another surgical procedure where we put a tube into the ventricle, into the spinal fluid chamber of the brain, and then we tunnel that under the skin, either into the jugular vein sometimes, or perhaps more often into the abdomen. And that tube just continuously drains off that excess spinal fluid. And most of these shunts we put in with a valve that keeps the fluid going the right direction and has a appropriate pressure setting to control that. So here you see in that, let me go back there. This picture here, enlarged ventricles before, and then smaller ventricles afterwards. So that shunt decompresses the ventricles and can help with the neurological consequences that it may be causing. And sometimes for an older person, what they really need is a shunt, and maybe they need less treatment for their tumor. Maybe we watch that tumor, or if it does grow, we can treat with radiosurgery. So again, each treatment is tailored to the patient's situation. So in these questions, should we do translab or retrosigmoid, or sometimes both? For a larger tumor, we may use a combination of these things. And so you see the preoperative MRI in the upper left, and the CT scans, which are very helpful for us understanding this bony anatomy, the mastoid, that pneumatized bone in the behind your ear. So by pneumatized, I mean that bone has a lot of air cells in it. Oops, sorry, skipping around there. So on this CT scan, those very dark spots are air. So the mastoid bone, that lump of bone you feel behind your ear, is to some degree filled with air spaces. And so when the neurotologist does the translab approach, all that bone is removed. So here's the after the post-op scan. So here's the normal mastoid on the left side with the labyrinth, those semicircular canals, the cochlea here, the internal auditory canal through which the 7th and 8th nerves travel. And over here, we've removed all of that to maximally remove the tumor. And in this case, this is some titanium mesh that was used to reconstruct that. And this is what the abdominal fat, the fatty tissue that, for a translab approach often will use to seal up that defect where the tumor was. So middle fossa, as I mentioned, sometimes is very helpful for a small tumor. So here's a very small tumor in the internal auditory canal. We can make this incision in front of the ear. In this picture, they show kind of a U-shaped incision. Most often for this, if we do the middle fossa, we do kind of a linear incision, sort of a straight incision here. And then we elevate that lining of the brain to get down to those critical structures in the internal auditory canal, down here where that 7th and 8th nerve travel, and hopefully being able to preserve hearing in that case. So radiosurgery, so there's a lot of devices out there for doing radiosurgery, and I've listed some of them here, and there may be others. At our institution, we have a long experience with Gamma Knife, more than 25 years or so, I think. It's a cobalt, radioactive cobalt-based treatment, but there are a variety of other techniques, and all of these techniques utilize radiation that's delivered with pinpoint accuracy. So that the name radiosurgery that somebody came up with decades ago. Sorry, this slideshow seems to have a mind of its own. So here's our current iteration of the Gamma Knife. We've had a few of these over the past few decades. This is the Elekta Icon Gamma Knife device. This one has a cone beam CT integrated into it. We can do a CT scan with it if need be. But the concept with Gamma Knife and also with these other devices as well, here's a CyberKnife device here, is all the beams of radiation are focused very precisely at the target. In the this particular Gamma Knife, the Icon, there's 192 cobalt sources. In the CyberKnife or other linear accelerator-based ones, it's a moving device, so it moves through these different planes, again, to focus the radiation very intensely at the target, in this case, the acoustic neuroma. So this gets a very intense dose right at the center, and then surrounding that, it's very little radiation. So a few pictures. Here's our current device. Here's one of our previous devices. And one of the advantages of this current device is, so the vast majority of Gamma Knife, at least, has been done with a STEREOTECTIC frame, this box, this halo, this XYZ coordinate system that allows us to precisely do that. CyberKnife and some of the other techniques have used masks or other ways to immobilize and register the person. The Icon device now also has a mask-based capability. For single-dose radiosurgery, as we do for the majority of acoustic neuromas, we still tend to use the frame because of the precision that it affords. But if somebody might undergo 3 or 5 treatments, for example, the mask allows us to bring them back day after day to do that. And then this is just from the software planning. So with the radiation oncologist and the physicist, we design what the treatment will be. We contour the treatment as precisely as we can, try to decide what is the critical target, and then how we can most accurately and safely deliver that radiation, bearing in mind where we think the facial nerve is, for example, which we can't actually really see on an MRI scan, but we have a pretty strong sense of where it is, like I showed in those surgical pictures, somewhere on the deep surface of that tumor. And then hopefully we get a favorable response of the tumor. And here's just one example where a person was treated, and you see that kind of small to medium-sized tumor there on the left. And then sometime after treatment, it no longer has that bright character. So on the left side of the picture, that bright character is the enhancement with the intravenous dye. And we see early after radiosurgery, a lot of that is lost as the tumor, in a sense, is killed or its blood supply is diminished. And then over time, hopefully we see it shrink and shrink. Now, as some of you mentioned or have experienced, sometimes these things get bigger. Maybe in 20 or 30% of cases, it gets bigger, particularly in the first 6 or 12 months before it diminishes in size. And whether that's growth or what I think it is most often is just a reaction of the tumor. Hopefully then it goes on to continue to shrink. But remarkably, we still see these things changing sometimes years later, 10 or 15 years later, we may see it still changing and shrinking. So it's a process and evolution over time. So some of the related things I think I just have a few more slides here. I can't remember how many, but so facial reanimation, as some of you pointed out, unfortunately, some of the treatments are associated with facial weakness or paralysis. Quite often that's a temporary thing that gets better on its own, but sometimes it's more dramatic or permanent, and we can require eyelid weights, for example. You see in this skull x-ray an eyelid weight there, sometimes other facial muscle or nerve reanimation procedures. I'll talk a little bit about hearing augmentation. Now, some of this, traditionally we did not think applied so much to the acoustic neuroma population, but there's growing evidence that in select cases that it may, and so that's an area of study right now. So the BiCROS device, probably many of you could tell me more about this than I know, but this is my simple neurosurgeon's understanding of it. So wearing the hearing aids on both sides, the sound that's transmitted to the non-hearing ear is transmitted to the hearing ear via using this near field magnetic induction technology. And so things on the side of the head of the non-hearing ear can be perceived on the other side. And with this more advanced technology, this can be transmitted with Bluetooth to cell phones or other devices to optimize that. And I'd be curious to hear some of your experiences with this, because some people seem to have tremendous benefit from these, and some people have not had great luck with this. There's another artist drawing of this. So here's the non-hearing ear and this well-drawn individual here. So the sound coming from this side here, that ear cannot perceive it directly because it's a deaf ear, but with the CROS device, it's transmitted to the other ear, which is not going to hear that as well because it's in a sense shielded. So it does augment that individual's hearing and the ability to localize sound in space, which probably all of you know better than I. That can be a great challenge if you've lost hearing on one side. So cochlear implants, again, often was thought not necessarily to be a viable option for vestibular schwannomas or acoustic neuromas, but there is some growing experience if somebody does have a preserved cochlear nerve that this can be done. In fact, Cameron Wick, one of our neurotology faculty, has an ongoing clinical trial for individuals with vestibular schwannomas. So at the time that we remove their tumor, let's cancel this message here. We might implant this cochlear implant if the intraoperative testing suggests that it's appropriate. So this is an exciting technology. This technology has been around for decades for other reasons and continues to be refined. And you see in this drawing here, so there's the device. There's an external device in the magnet, and then the internal wiring that goes down into the cochlea, that teeny tiny little snail-like structure that's even smaller than you see in this drawing here that our skilled neurotologists can send this very delicate little wire into. And then the auditory brainstem implant, or the ABI, and this is a little bit more apropos for the NF2 population, or people with bilateral deafness. We just put one of these in a 5-year-old child a couple of months ago. But rather than that deep wire going directly to the cochlea, it goes beyond, it goes to the brainstem, to the cochlear nucleus, that very part of the brainstem that receives that auditory signal before it sends to other parts of the brain to be processed. And so in that case, this little electrode is placed right on, directly onto the brainstem. And this is not so much as robust in terms of sound perception or speech recognition like a cochlear implant. The auditory brainstem implant, in my understanding, is more of a sound awareness, which is still tremendously beneficial for some individuals, and then some people augments their ability to lip read. Here's just sort of a cartoon depicting the difference between those two. The cochlear implant with a wire directly into the cochlea, that little snail-like structure in the temporal bone, as opposed to the ABI, the auditory brainstem implant, with that electrode that we place directly on the brainstem itself. So in the last few slides, so some of the challenges, and one of you told a story that's a little bit like this, and we still don't have a perfect solution to these situations. So here's a woman who some years ago in her 70s was found to have a small tumor. She chose the watch and wait strategy, and hers grew faster than average, which happens in just a small percentage of these tumors. And so at that time, she chose Gamma knife using a very standard 12 gray to the 50% isodose line. And unfortunately, despite that, this stubborn tumor continued to grow. And so sometime later, we did a translab approach, and we were, fairly conservative in that, leaving some tumor attached to her nerve and brainstem. And unfortunately, this stubborn tumor continued to grow. And you can see now she has a tumor far bigger than she ever even started with. So she's undergone another course of radiation with hypofractionated using a mask-based technique. And hopefully we can control that this way. But there's still some of these tumors that we don't quite understand and don't have a perfect strategy for the biology yet. Just another example of a tumor that's grown after radiosurgery. You can see the stereotactic frame on their head at the time of the Gamma knife, and then sometime later the growth, and that individual also underwent a translab approach. So just a few notes. There's their that individual's audiogram. You'll see early on, kind of not great hearing, but probably a little bit of utility in that hearing. Then over time, unfortunately, that declines. So I'll just briefly mention NF2. So as many of you probably know, it's a condition where unfortunately these individuals, often even at a very young age, will have bilateral vestibular schwannomas, right and left, and unfortunately many other tumors, meningiomas and other schwannomas and tumors in their spinal cord and other places. And it's autosomal dominant, meaning that 50-50 chance of them passing it on to their offspring. So this is a very challenging, this so-called benign disease really is a disabling and challenging problem. But many of the things that we're learning from NF2 help us, I think, better treat individuals with sporadic vestibular schwannomas. Here's a young gentleman with a fairly large burden of tumor with NF2. And you see the decline in the hearing. When these red-blue lines are at the top, that's favorable, and the lower these lines drop, the worse the hearing is getting. So some of you may be familiar with this gentleman. So Scott Plotkin is a neuro-oncologist in Boston, and he was among the early adopters of this strategy of using bevacizumab or Avastin, a chemotherapy or an antibody strategy that's used for a number of cancers. But they found that in certain individuals with NF2, we could see shrinkage of the tumor. Now, it's a very intensive intravenous treatment every 2 weeks, and perhaps no more than 20% of individuals respond. But as an early sense that we do have medications or biological treatments that might be helpful. And so on rare occasion, we've used this in sporadic vestibular schwannomas, mostly reserved for NF2, but it's one of the early promising strategies as a medical therapy. So some of you may know these individuals. So Mike is a good friend of mine up there at the Mayo Clinic. And his Colin Driscoll on the right. We've taught many courses together and things. And so they interestingly looked at quality of life, which I think ultimately is the goal of all of this, is not to make a perfect MRI scan and so forth, or a perfect audiogram, but the individual's quality of life. And so they gathered individuals from numerous institutions, 600 some here you see, to try to figure out for acoustic neuromas, what are the issues in terms of quality of life and how we can best manage these things. And so here's their conclusion. And so they describe the differences, and these are metrics of quality of life. There's surveys and different ways to measure quality of life, and they used a number of these. And they said that the difference in outcomes, whether it's radiosurgery or observation or microsurgery, are actually very small. That in the long run, if these treatments are applied appropriately to the right individuals, they all do pretty well. That rather than the difference from one treatment to another, maybe the things that affect that individual's life more than ever are the fact that they have the tumor at all, as opposed to the general population. And then they go on to say that since a large number of these tumors, don't seem to grow or grow very slowly, that often intervention at the time of initial identification, may not be appropriate. That for small, medium-sized tumors, a careful watch and wait strategy is often optimal. So again, tailor fit to each person in their situation. So lastly here, considering treatment options requires complex decision-making between the physicians and patients and their families, and taking into account all the characteristics of the tumor and the individual's medical history and goals and desires and expectations and other factors. So I hope this was of some interest to all of you, and shares a little bit of my perspective, which comes from treating many people for the last 20 years or more with these tumors. But I'd be very interested to hear any of your comments or questions if there are any.
Great. All right.